Thank you. It's a pleasure to be here, and I thank Leslie for the generous introduction. I have these disclosure slides that I was asked to include in my presentation, so I'm not, I don't have conflicts of interest in what I'm going to talk about, and I'm not selling you anything. So you don't have to believe anything I say. What I wanted to talk about tonight is what are the entitlements of a progressively realized domestic moral right to health, and what function must better global governance involve if there is to be a global right to health. I want to emphasize that the appeal to global governance is very widespread. It's a buzzword in health policy now, and so is the appeal to a right to health. So I want to talk a little bit about, if you really mean what a right should mean, then what sorts of functions would you have to consider, and are they going to be possible at a global level? And that's the argument I want to make, is that it's not an impossibility theorem that I'm going to be arguing for. It's an improbability result for an approach. And I'm very interested in any comments you have about what this implies for concerns about aspirational justice. Because often claims of justice are said, oh, that's just an aspiration. And I'm not, part of what motivates these remarks and the argument I'm going to make is the view that some view about the relationship between claiming that we ought to do something because it's required of us and the idea that it's possible for us to do it, it's feasible for us to do it. So the motivating concern is, what is the relationship between justice and feasibility? And that's what I'm going to push on, and I come up with a conclusion that I'm not very happy with, because it seems to undercut a lot of the talk we hear about there being a global right to health and the appeal to better global governance. So that's a view that I'm not specifically happy about, but I'm stuck with. And so you're going to be seeing the implications of following an argument to its conclusion, at least as I understand some of the claims in it. So I want to start with a discussion of what the entitlements of a progressively realizable moral right to health might be. I think this is a very important issue, and it's one that arises in the effort in a lot of Latin American countries now to address the concerns that they have about a right to health, which is in their constitution. So can courts decide what the entitlements of people to health care are based on the claim that there's a right to health in that population? And I've in the past said I don't think so. It's not really the task of the courts to do that, even if health systems don't do it very well themselves either. But one of the crucial points that I'd want to make, I don't know if this has a laser.
In the middle of the top.
Okay. So I wanted to talk about the fact that if you're going to be concerned about a progressively realizable right to health, you have to be concerned about the resources you have to meet those needs. And so a right to health in general would have to be something that is sensitive to the resource levels of the society in which you are. So what's feasible in the UK is not necessarily feasible in sub-Saharan Africa. So even if there's the same right to health that you want to claim, you can't really deliver on it in the same ways in those two settings. And if you were to ask the question, what are people's entitlements to health, that might be a different story in the UK from what it is in South Africa or Malawi, to pick an even poorer country. So I wanted to talk a little bit about the implications of theory of justice, which is a view of justice that I have worked on for some time, since John Rawls developed it in the early 70s. It tells you it's a long time for one person to be working on something. And I want to talk a little bit about the specification of entitlements to health that come with positing such a right, because there's almost no discussion in Rawls of that issue. So I want to talk a little bit about what's captured in the second to last bullet there, that there's got to be an institutional basis for specifying entitlements. In many countries, this is whatever the health system decides people should get, decides their entitlements to care in that system. My view is that that shouldn't be the way it is, that we could do better. Jim Sabin, who's a psychologist at Harvard, and I worked on, before I went there, worked on an approach that was a process-based approach to thinking about the conditions that a fair deliberative process for deciding what the opportunity costs would have to be. But there are very few models of that in the real world. So I think of this as an undelivered promise of a tool that might be used to determine what counts as a fair deliberative process. Nevertheless, entitlements are specified within a right to health, whether or not that country is in the grips of a theory of justice of the sort that I will describe. In addition, each country is capable of developing the funds necessary for delivering on those entitlements. And I think of that as truer in some countries than others. It's not something that every country lives up to, but the idea is that it could be lived up to by all those countries, and we have models of some nations doing that. So let me describe a theory that I pushed in the late 70s and early 80s, and it has become a dominant view about in a lot of thinking about the relationship of a right to health to views about social justice. So the basic idea is that disease and disability impair the opportunity range that's open to people. Whereas health protection, we can think of this as both the public health interventions that protect population health and the medical interventions that treat people who are sick or prevent individuals from getting certain diseases when, even when they're healthy, that this protection can, of health can protect the range of opportunities open to individuals. I was interested at the time in the fact that a lot of countries around the world treated health as different from other social goods they distributed, in that they thought that health ought to be protected more equally and equitably than other goods. In my mind at the time, this led to the claim that health was of special moral importance. That, and how could we give a good account of that? The answer I came up to that question is that health is directly and intuitively connected to the range of things we can do or be, to use Amartya Sen's phrase, the opportunities we can reasonably exercise in pursuing health. And so on this view, I think that health is of special importance because all of us tend to believe, at least we avow, even if we don't act on the view, that there ought to be something like fair equality of opportunity in a society. And if you're protecting the health of people, then that becomes the principle of social justice that would describe the approach that should be taken towards health. So the argument I was making is that there was a reasonably good fit with the Rawlsian theory of justice. And I will say a little more about Rawls's theory, pointing out that this broadens the notion of opportunity and in ways that could be criticized and have been in the literature. So in Rawls's theory of justice, which is a social contract theory, the idea is that if you put people in a fair situation and ask them to pick principles of justice or terms of fair cooperation they might pursue, they will, in that fair situation, pick the principles that I've listed there at the end of this. I call it 3 principles, Rawls calls it 2, and that's because the fair equality of opportunity and the difference principle are both clauses of this, his second principle. I don't care whether you call it 2 or 3. There's a simplifying assumption in Rawls's theory, which has also attracted some criticism. So the simplifying assumption is that people who are going to contract and arrange for these fair terms of cooperation to exist are themselves healthy and live a normal lifespan. So he's abstracted in this situation from the real world in a very serious way. There's no premature death, and there is no health inequalities that would exist, and people's health needs are gone. It's not surprising that in the theory of justice he didn't talk about health, except to say, I think erroneously, that it was just a natural good. Ignoring what was emerging didn't become fairly well known in the public health literature until the 1980s, that there were a lot of determinants of health besides medical care. So some people in public health argued that long before Rawls' theory was developed, but he was not aware of a lot of that and didn't reflect on that literature. So the simplifying assumption, namely that people live a normal lifespan and could pick principles of justice and fair cooperation for their society, was on the assumption that health would not be a problem in that society, at least to start with. He always had the view that you'd have to relax that assumption to proceed. And that's what I worked on for a long time as after the theory of justice came out in 1971. So on the view that I'm describing, and in the particular, let me go back, in this slide on health opportunity and roles, I thought I said something about a right, but I guess I didn't because it's not there. I intended to say something about how a right to health would fit within this view. And the particular argument that I want to make is that a right to health is a special case of a right to a fair equality of opportunity. And that's the good fit with the Rawlsian theory that I'm proposing. So if we go back to the entitlements of a progressively realizable moral right to health, you have to assume that you've, in a world in which you've relaxed this assumption that everybody is healthy and that there's no premature death, which Rawls thought was a good starting point for the development of his theory. And you would do so in the approach I'm taking by suggesting that we can relax that assumption because we can address the concerns of health and health care around the world by thinking about protecting the opportunity range of individuals. So that's the idea that I had, and which led to some work in the early in mid-80s and early 80s in extending Rawls's theory. But all of that was done without thinking about the various determinants of health that were much broader than medical care. And so I attended a seminar at the Population Center at Harvard, and it was in that setting that I was exposed. I was also a Robert Wood Johnson Fellow at one point and was surrounded by people who were working on health disparities. And I worked with someone who later became a chair of another department at the School of Public Health that I'm in now, Ichiro Kawachi, and I worked with him and another colleague of his who were both on the also RWJ fellows at that time, and we were focused on how would you include the concern about these other determinants of health in a theory of justice for health. So the idea is that the principles of justice that I articulated happen to capture a lot of the key social determinants of health if you think of them in a broad enough way. Just to take an example, one of the arguments is that differences in income and wealth are known to affect the health of people and the health status of people. And so if you've reduced the gaps in income and wealth as much as you can, which is what the difference principle calls for, then you perhaps would have flattened the socioeconomic gradient of health as much as you can. Similarly, if you've addressed the concerns of the fair equality of opportunity principle and included a range of early childhood development measures in your approach, you might have addressed some of the advantages that allowably better off individuals and groups have in a society over others. Of course, this presupposes that these are funded in an equitable way and they're of decent quality and so on, all of which arguably are not true in most of the world. But the argument is that if you did do that, then you would have also flattened some of the important contributors to health inequalities around the world. Simply protecting the equal basic liberties would also do that. Especially protecting the fair value of political liberties, which Rawls emphasized in his work. So the argument that I'm making is that a right to health has to include protection of the preventive measures that might be included in addressing the fair distribution of the social determinants and other determinants of health, but also it would assure people that a medical care system was appropriately designed to and judged to protect health of individuals. And the medical care system, of course, is focused on people who know they're sick or who are identified as sick and have ill health. Whereas a lot of the other measures don't identify people in a clear way. And that may be one reason that public health is not as widely supported as medical care, is that people think of themselves when they're ill as identified victims who can legitimately ask for assistance. But if you're well, because a lot of measures have been taken to distribute the protections fairly, you don't know whether you're well because you're lucky or you're well because of what someone else in society did for you. So you don't have that going for you. And that may explain some of the difference in the funding levels of public health measures and medical care. In the work I did with Jim Sabin, we were interested in the fact that reasonable people would disagree about what kinds of measures to take in promoting a fair distribution of resources in a health system. And so we tried to identify some conditions which, if they were met, would work even in, and our model was the United States. a system in which there was a lot of fragmentation of the healthcare system, not a lot of unity, as there might be in some other systems, and in which there was a very well-developed private sector that was delivering a lot of health. And I'll come in a second to one of the problems with the view that we were articulating. So we were suggesting that you could capture a lot of the legitimacy enhancing and other fairness enhancing components of healthcare decision making by making the system very transparent. That's what the publicity condition is supposed to do, and focusing on providing rationales to people for why certain items were included among the resource allocation decisions and others were not included. Being very, so the relevance condition was supposed to focus on conditions that everyone thought would be relevant to making decisions in a fair and legitimate way about what should be included in the healthcare system. Our goal was to reduce the amount of disagreement that existed about what to include and not to include, not to eliminate it. So there are certain questions we didn't answer, like what should be you might think these are fundamental questions that any philosopher, and Jim was not a philosopher, should answer. So that was aimed self-critically at me. Namely, if you're going to propose something as a process, wouldn't it have to include a rule of decision-making? So what if you didn't have agreement? Is the decision going to be made by consensus or by a majority rule or a supermajority rule? And we wanted to leave that up to decisions that were made in each society, and whether you're at different levels. So you might have some decisions that were made by consensus, as the decisions in the NHS are supposed to resolve disagreements geographically that might exist about allocations, and to remove postal code, what are called postal code differences. So if you could get a treatment in, let's say, Oxfordshire, but not in Cambridgeshire, that would be a problem in a national health system that talked about everybody being treated equally. So the National Institute of Clinical Excellence was supposed to eliminate those postal code variations through its recommendations. It's interesting that in NICE in the UK, there was an effort to find out what groups of citizens would think about certain social issues that might be related to the relevance condition. So could age ever be taken into account? Might be an important question in resource allocation. One of the problems with the macroeconomic view of health that is dominant in a lot of the discussions is that it says health is important in a society, excuse me. Health is important in a society because it promotes productivity, but what about all the elderly who soak up so much of the healthcare budget? They don't produce a lot, yet they, in every country, every developed country chew up a lot of the budget of the medical care because they get sick more often and need more help, and that's the basis for perhaps they're having a spend on health care of 3 to 4 times what a younger person might have. So we have, it's interesting that in the UK, Michael Rawls, who was chair of the NICE when they brought into the Citizens Council into existence, argued that they ought to consider social issues so that our approach is not just informed by the cost effectiveness thresholds that we are mandated by law to use, or the emphasis on cost effectiveness that we use in the UK, which is not used in, let's say, Germany. He argued that we ought to know what citizens think, and quite to the surprise, I think, of NICE, the Citizens Council rejected letting age be a part of the decision-making criteria for healthcare. And that's not something they officially disapproved of, although they rejected some, as NICE as an institution rejected some recommendations of the Citizens Council. The reason I mention the Citizens Councils is that it's in our discussion of accountability for reasonableness, using the US model, we didn't talk about including a broad range of stakeholders, although in all of our writings about the process in countries that have publicly administered health systems, we did talk about the importance of including a broad range of stakeholders in decision-making, so that our argument was not that it enhanced democracy, but that it improved the degree to which you were actually listening to a broad range of arguments. So our view was that you could get a broader range of arguments by hearing more stakeholders. Of course, that poses the problem of how do you manage this discussion? So I'm hoping that some of you have some good ideas about that, because we didn't. So let me conclude by coming to the theme of this particular talk. I was responding to a call in Larry Gostin's recent book on public health law, called Global Health Law, and published last year, or 2 years ago now, for better global governance. And he has proposal, has in the past proposed a framework convention for international agreement on better health governance. And this is modeled in part on the framework conventions for tobacco control. So the idea is that if you had better global governance, then you might realize some of the functions that I'm talking about for health. If you wanted to posit a global right to health, you might have agreement that there is a better global institution for specifying the entitlements to a right to health care. And you might have some enforcement globally of the raising of funds and what the shares of different countries would be to do that, which we don't have in the world today. So the appeal to better global governance has a rationale. And I was concerned, and I still am, that this faces an important coordination problem. So I want to describe what would happen if you did appeal to better global governance in a world filled with nation states. And that's the world we live in. Some philosophers lament that fact and argue that nation states are the bane of all evil, all existence, and they're the cause of all evil. But they're the world we live in. Unless one has a proposal that could plausibly lead to their elimination, then one has to think about strategies for including them in, and that's what indeed the human rights strategy did. It said there's a human right to health and a human right to education and a human right to all kinds of things. Every country can be a signatory to agreeing to these rights, but we're not going to do anything but acknowledge the fundamental obligation of states to implement those rights for their citizens. And internationally, states have an obligation to assist other countries in doing that, but there are no enforcement mechanisms for those obligations. And if the obligations in healthcare were to make sure that the appropriate entitlements, given the resource levels that each country had, were specified, so you knew what each country should be able to provide in entitlements to healthcare, and you could raise the resources through some mechanism. If it wasn't possible to do that globally, because we don't know how to design those institutions or get that agreement from all the countries of the world, then we face this, what I'm calling a coordination problem. We have the low probability of getting these global functions, of specifying entitlements and funding them, ever implemented on a global scale. So this is not an impossibility theorem that I'm arguing. I'm not saying we couldn't do that. I'm just saying that we're unlikely to do that given the resources we have. And this is intended to be a warning against loose talk about better global governance. But it's not a warning against trying. It's a warning against claiming we know what justice requires rather than simply believing what justice requires. Because many people might believe there's a global right to health and want to improve global governance to achieve that, and I would encourage people to try. But we have never seen any federation of states in the globe coordinate their efforts in a way that would have to be done in order to say there is a global right to health. And here's what it means. It means you have these entitlements with this level of resources, and not only that, the globe will ensure through these mechanisms that we can fund those entitlements. If we lack those institutions globally, then I'm saying we don't have or shouldn't talk about a global right to health except as a belief that we have. And the worry I have is that, to go back to what I started with, I worry that this argument would discourage a lot of people from trying. So is this view biased toward the status quo? In which case, I didn't come out where I wanted to come out on this, because I don't think the status quo is very good. So why don't I stop and take some questions that I think you must have at this point?
Thank you. The idea of having a right of global health is good, but I think why people must be discouraged is so much discrepancy between the nations about population and resources, corruption in the individual nations. So it is a humongous task for to initiate that kind of philosophy and actually put it into practice. What are your thoughts on that?
Well, I think it's very hard, and yet there are people who will try their hardest to do it. And I don't, as I said, this is not an impossibility theorem, it's just an improbability theorem.
Hello. You're in your talk. I guess, and I hope I'm
I'm sorry, I'm having a little trouble.
Oh, hello?
Yeah, I can hear that now.
Sweet. Well, I guess my question is more about the intersection of culture, health, and business. I'm thinking more about from medical patents to the flood crisis and how that had so much to do with business interests and how public health could have a hand in, especially with enforcement and regulation globally. Businesses control resources, medical and otherwise, and maybe is that something that is possible, or?
Well, did you have in mind the slowness to develop certain kinds of medications that might meet a global burden of disease? Because they're not going to be that profitable for drug manufacturers in developed countries? Is that what you had in mind? I think there are many different projects that I would encourage people to try their best to produce better regulation of, and that would be one. I'm not sure what the best approach to that is, whether it's modifying intellectual property laws or providing some other sort of incentive like Tom Pogge is proposing with his Health Impact Fund. So you might have a lot of approaches to that. What I'm skeptical about is whether, given the enormous power of drug companies working on the political system, will they undermine the ability of some countries to agree to a better strategy for meeting population health needs? So my view is that Pogge's model is got a lot of problems. The Health Impact Fund is supposed to determine ahead of time what the impact is of a particular drug on the global burden of disease, and that's how you would incentivize the development of such a drug. But no drug works without being delivered to people who need it. And that means it's not just the drug, but the health system that delivers it that matters. I don't see that he's got a good answer to the question, how do you incentivize companies to do that with the health impact fund? So that's a fairly specific remark.
Hello, my name is Adam. I don't know, my understanding is that you are espousing a state-centric view of right to health, if I'm not correct.
I don't know if I'm espousing it or noting that that's what we're stuck with.
Because the full point is that I think the whole concept of the idea of right to health emanated from this UN Universal Declaration of Human Rights that has the right to high attainable health for every individual. So without some form of national health government setting up the framework for states, how can individuals be states maybe agitate or advocate for right to health?
So, if I understand the point that you're making, who is the duty bearer of such a right? And what I was arguing is that there has to be a duty bearer if there's going to be a right claim. And if it's some vague appeal to international assistance, that's not going to do it. So my view is that some of the opposition doesn't have to the view I've been describing, doesn't have a clear description of the duty bearer in such a right. And I take it that every right has to have a duty bearer, otherwise it's not a right. That's part of the conceptual analysis of rights that I subscribe to.
Yes, sir. How long do you feel that Rawls' theory of justice might go into the ongoing discussion about climate change and global warming? And would you be similarly pessimistic about the outcome of that debate if it maps onto Rawls' theory well?
Well, I was surprised that there was any agreement at all in Paris, if that's what you're asking. I agree with the critics that it's very short of being adequate to meet planetary needs. And my guess is that only if you find a few cases, like we're all going to burn up or something like that, there's a threat from domestically or from outer space that is going to eliminate this crazy world of nation states. And make them cooperate together to fight a common enemy. Only if that were to happen would you oppose what I'm suggesting. So maybe there will be enough awareness of the problem. One of the issues is obfuscation of the science. Which we've seen in spades. We saw it in the tobacco efforts, and Naomi Oreskes' Merchants of Doubt book suggests that we're facing the same problem in a climate change debate. So I support that view. I think that that's true, but it creates a real problem in the world if people do not understand that humans are responsible, as best science can tell, for the global warming that we're experiencing. I don't know whether this past winter is a good example, but you could say, well, any one event in the climate is got too many causes to attribute it to something like global warming. It may just be an El Nino effect or something else. But it's that there is global warming is clear. That humans have let carbon dioxide into the air and fossil fuel pollution in ways that could have disturbed this balance. That seems to me to be established. Whether that's the actual cause or not, I suppose we are stuck with believing as seeing view that I think undercuts science a lot. So thank you for your question.
My question or comment was really a follow-up of the situation. The area that I work with is environmental health, and I mean, it would seem to me that hopefully we won't have to wait to find someone from the outer space to actually get heads together, to work towards a common goal, since it seems to me that climate change really poses serious threats with regards to water availability and availability of even food resources in the future. So it would seem to me those conversations, you don't hear them here, but at least I have seen people from the European Union talk about these things and be very clear about the need for sustainability and to, hold back. It would seem to me that if indeed, it seems to me, we start to have scarcity on basic resources, then maybe an idea of a common way to handle all those things could be possible, and perhaps that would be like an avenue through which the aspect of health and overall health will be, kind of looked better and just kind of be addressed from the way that you're presenting.
So your suggestion is that this is too pessimistic because people will see the value of health as part of the awakening that they have. Is that your view?
I mean, it seems to me pessimistic. I would rather want to think about being proactive, and the truth of the matter is that conversations about the need to look at humanity and the basic needs of humanity and how to supply for those needs is important. So it seems to me that climate change and our current climate situation would push that conversation, and at least it's being pushed in some circles, maybe not in this country, but in others. So at the governmental levels, so it would seem to me that that would be like a very good place to actually also talk about, health within the context of a basic need that also needs to be looked at from that same context as other basic needs should that situation arise.
So I'm happy to be proven wrong about this argument I made about health, and if you can get a lot of agreement among countries about sustainable energy sources, I would welcome that. What I note is that as a participant in the divestment efforts at Harvard. We are faced with an administration that says we've got to get our endowment up and the investments it makes because I gather the evidence is that Harvard wasn't doing as well on some of its investments as some other schools were. So they've doubled down on the anti-divestment effort and said they've got to invest more in failing energy places. So you may see a lot of investment in the failing fossil fuel industries that you see around the world, because Harvard may see that as where it has an opportunity to gain. So my view is I hope they're wrong. And I'd like to see them lose a lot of money on that gamble. Because I'm retiring.
Hi, I'm Jackson Williams, and I'm a clinical physician as opposed to a philosopher, so I don't know how this will come, but what is your view of the Millennium Development Goals and more recently the Sustainable Development Goals in view of the philosophical arguments that you're making? From my perspective, the Millennium Development Goals did do quite a bit to at least provide some framework for how we might begin to address some of the global health inequities. Do you think the problem, based on the philosophical argument that you're making, is one of enforceability, or how do you view the MDGs and now Sustainable Development Goals within the framework of this argument?
I guess a lot of the argument I'm making comes down to enforceability. So none of the Millennium Development Goals were enforceable. Neither are any of the Sustainable Development Goals. So I'm guessing that what we'll find is ongoing progress towards some reductions in mortality and morbidity rates in some conditions. But a failure to do anything more than say that's a problem and let's address it. And
one last question.
Hi, I'm just curious about what's your view on World Health Organization and its
World what?
World Health Organization and its political leadership in directing global health.
Well, I guess my view is quite mixed. I think they've done a lot of good things, and I have questions about some of the other strategies that they're following. But I don't think that distinguishes me from a lot of people.
Dr. Haynes, thank you very much again for the lecture. As always, we have some parting gifts for you. We have the infamous blue box that we can ship home to you if it doesn't fit in your carry-on bag. And then, now that Julio has left, you will become the only honorary professor in the ETSU College of Public Health who's at Harvard. So congratulations.
Thank you very much.